Hey, Drugs and Behavior students, it's Dr. Gilchrist, and we are going to finish up our last set of lectures for the semester by talking about anxiety disorders and their potential treatments. So here's what we're largely going to cover. We are going to talk about some of the different characteristics of anxiety disorders. We will also talk about obsessive-compulsive disorder as well as post-traumatic stress disorder, despite the fact that as of the publication of the DSM-5 in 2013, neither of these are technically considered anxiety disorders, though they do have some very similar features to anxiety disorders. We'll talk about some of the neurobiology of anxiety disorders. As you can probably imagine, for anxiety, the amygdala is going to be pretty critical here. And then we're going to talk about the drugs that we use for treating anxiety, OCD, and PTSD. So let's go ahead and start by talking about some of the major characteristics of anxiety disorders. So there has been a recent update of anxiety disorders. As I mentioned, as of the DSM-5, they have reclassified anxiety into three major categories. First of all, there are your anxiety disorders such as generalized anxiety disorder, panic disorder, phobias, and things like that. We have obsessive-compulsive disorder, which is often considered more of an impulse control disorder, as well as other related disorders. And then we have trauma-related disorders, including post-traumatic stress disorder. So one of the things that your book mentions that I think is really relevant is that it's very, and especially when I was growing up and learning about psychology and different types of disorders, it was very common to hear talk about how depression was the most common disorder. It was often referred to as kind of the common cold of mental disorders because of how often people display it. One of the things that you may not know is that anxiety disorders in recent decades have become more prevalent. According to your textbook, as of 2013, prevalence of anxiety disorders, including PTSD and OCD, is about 7.3% globally. They are more common in women than they are in men. And they're also equally prevalent across age groups. In terms of lifetime prevalence in the United States, at least 1/3, or about 33.7%, have had an anxiety disorder at some point in their lives. Most of these are either going to be specific phobias or social anxiety. And then at least 1/4 of those that are experiencing an anxiety disorder are reporting PTSD. And then the remaining are things like panic disorder and generalized anxiety disorder. So these disorders are becoming a lot more common. So anxiety manifests itself in many different ways, depending on who you are. This can include panic episodes where you have these moments of dread and terror and extreme amounts of panic. You might think you're about to die. Avoidance of anything that elicits anxiety. So somebody who has something like social phobia or social anxiety might not be very interested in things that involve public speaking. Intrusive thoughts or compulsive behaviors, such as you might find in OCD or generalized anxiety disorder, and very damaging negative thinking patterns. So especially for this group, things like cognitive behavioral therapy can be really useful. We also know that anxiety is comorbid with other types of psychopathology, such as clinical depression. Depression and anxiety are very common, and as we learned last week, for many people, anxiety will often precede a depressive episode. Now, what are some of the hallmarks of these disorders? So these disorders will often include feelings of concern or worry, increased muscle tension, restlessness, impaired concentration, sleep disturbances, and irritability. So one of the things that really separates anxiety disorders from things like depression is the energy level. So depression may often be marked as having very, very low energy or feeling burnt out. Anxiety is going to be marked by having a constant high, tense state of energy. And part of the reason that this happens is because of the activation of the sympathetic branch of the autonomic nervous system. So for these people, what can often be really critical is getting that sympathetic nervous system under control. This can produce things like increased heart rate, sweating, and other types of signs of the fight or flight response. So for example, I occasionally struggle with morning anxiety, particularly when I have to be at a certain place at a certain time. So if I'm rushing in the morning, and especially if I've had some caffeine in my system, my fight or flight system gets going and my heart rate kind of spikes to levels that I normally don't see unless I'm working out. When I don't rush, I notice that my heart rate is more normal. And so that's kind of an indicator that maybe for me, rushing around produces an anxious state. Now, some anxiety or fear-based responses are really helpful. So fear is often a response to things that are currently happening. Anxiety is often a response to things that might happen. So it's much more focused on hypotheticals that may not happen or have yet to have happened. And let's be clear, anxiety is in some ways beneficial. It has enabled our survival, and it also helps us to take necessary precautions to help permit our survival. It helps warn of danger, and it activates your fight or flight response. Now, in modern life, the fight or flight response is not always going to be very helpful. When you need to make a speech, that is the last place that you really want to start having that come into play, because it's going to affect your ability to do well. Likewise, if you're taking an exam, that fight or flight response may end up negatively affecting your performance, causing you to freeze up and thus not be able to do well. Now, let's be clear, a little bit of arousal and energy can be really helpful. We do know that arousal can be a way to help you get focus. It's part of the reason why for a lot of people performing on stage on opening night, that is often going to be a better performance than they gave during a dress rehearsal where there's a lot less anxiety. But at some point, this anxiety will become overwhelming to the point where it negatively affects your performance in a lot of different ways. So here are how our body tends to respond to situations related to stress. So there are a lot of different things that can cause us stress. And let's be kind of clear that even good things can be really, really stressful. But we're largely going to focus on negative stressors. So that can include things like failures or the potential for failure. That can include things like personal losses, frightening events, time pressure, like deadlines or getting ready in the morning, or insults. So your brain basically perceives this as a threat. And so this will cause a variety of different bodily effects, as you see here. So the autonomic nervous system, particularly the sympathetic nervous system, is really going to kick into gear. Additionally, there's going to be shallow breathing, and one thing that I can definitely tell you is that shallow, rapid breathing actually can have the ability to make anxiety worse. For people that struggle with panic disorder, one of the things that we actually know is that if you look at their respiratory levels just before they have a panic attack, they are breathing themselves into hyperventilation. So what's often very important for people that struggle with anxiety is to check their breathing. Oftentimes, we're going to find that people are hyperventilating themselves into an anxious state. So if you're already anxious and you engage in this shallow breathing, it's going to make things worse. You feel a pounding heart, your muscles are going to tense. Remember that when your sympathetic nervous system is kicking into gear, digestion is inhibited, so this may manifest as digestive problems, sleep disturbances for a lot of people with anxiety. Being able to sleep and shut their brain off can be very difficult. Being in this high energy state for a long period of time can lead to fatigue, as well as psychosomatic illnesses, feeling like there are problems with the body. We will also have upsetting thoughts, anger, fear, preoccupation, self-doubt, negative self-talk, repeated danger thoughts for those that struggle with health anxiety, possibly worry about their body reactions and their health, which ends up making the bodily effects worse. And both of these may lead to ineffective behaviors, and these ineffective behaviors will also reinforce the upsetting thoughts and bodily effects. This includes things like escape behaviors, avoidance behaviors, indecisiveness, aggression, rigid and flexible responses, poor judgment, inefficiency, and drug use. So these all kind of feed into each other and make managing stress worse, and they make the anxiety worse as well. So what's the relationship between anxiety and fear? So fear is focused on the present. It is an emotional response to clear and current danger. Compare that to anxiety, which is more amorphous. It's apprehension about future events. So fear is present focused, and it is a natural response to current present events. Anxiety is entirely focused on a hypothetical situation that may occur in the future or may not occur at all. In addition to the time course of focus, they will also differ in terms of the psychological consequences as well as the neurobiological consequences. So let's start talking about some of these different disorders. So we're going to start by talking about generalized anxiety disorder, or GAD. And this is something that, well, I know about pretty well. So generalized anxiety disorder is marked by constant worry and continuously predicting, anticipating, or imagining dreadful events, a lot of dwelling. Life is generally going to be pretty stressful. Even minor events will provoke worry. And here's what's kind of interesting. So Freud kind of termed this a free-floating anxiety, and it really is, because there's not a specific target with generalized anxiety disorder. It is constantly shifting. Everything provokes anxiety. And this chronic anxiety will reduce the individual's performance on many tasks. It decreases pleasure. And with GAD, some of this does seem to be due to how somebody is wired. If you're the kind of person that is prone to overthinking or overanalyzing or prone to ruminating, or you're the kind of person that information gathers to kind of help solve problems. So if you have a problem, you like to information gather and collect information to figure out what to do. Some of this is very much a pattern of thinking and a pattern of wiring. And so for a lot of people that struggle with generalized anxiety disorder, they're going to go through episodes throughout their life where the GAD kind of pops up. Remission is pretty common, like I said, because it occurs in episodes. But for somebody who struggles with this, there is the possibility that they're going to be struggling with it the rest of their life. Now, this doesn't necessarily mean medication for the rest of one's life, but it does mean if you have GAD, finding very, very good ways to help you cope with anxiety. And especially if you're somebody who is always focused on future events that have yet to happen, I can tell you that mindfulness and trying to stay in the present moment can be incredibly useful. It's not a cure-all, but it's incredibly helpful. So GAD affects the amygdala. So one of the things that we do find is that the amygdala will actually increase in its volume, very similar to what we would find in laboratory animals that are exposed to repeated stressors. And additionally, when we've looked at its metabolic output, PET scans, so a PET scan, just as a reminder, we inject you with a radioactively labeled form of glucose, and we're basically trying to see which areas of the brain are more metabolically active. Areas that take in greater amounts of glucose are assumed to be more active. So PET scans in people with generalized anxiety disorder, they tend to have greater amygdala activity when they are exposed to negative stimuli like negative words, negative images, than in healthy individuals. So somebody with GAD is more, not necessarily more able, but they are always on the lookout for potential threats, and they see threats where others may not necessarily see those threats. So let's talk about panic attacks and panic disorder. So a panic attack is an effect of a fear reaction in the absence of a threatening stimulus with very, very strong arousal of the sympathetic nervous system. So you can have a panic attack and not have panic disorder. Panic disorder is when the person experiences both panic attacks as well as anxiety over the possibility of having an attack in public. So you can have a panic attack out of the blue, and this is very common in people with anxiety disorders. But if you don't necessarily change your life or change how you're living your life to try to prevent those attacks, that would not be considered panic disorder. If you are trying to restructure your life to basically avoid panic attacks in the future, that would be more emblematic of a panic disorder. So panic attacks can lead to what is called agoraphobia. So one of the things that we find is that a lot of people who have a panic attack, usually some have a panic attack due to a very subtle stimulus, but for a lot of people with panic attacks, they feel like they come out of the blue. But they often tend to happen in public places because, well, we tend to live our lives in public spaces. And so for people who struggle with panic attacks, they may develop a fear of public places or other situations where they've had panic attacks as a way to try to exert control over whether or not these happen in the future. And this will often lead to avoidance of common situations where panic attacks have occurred, such as being in public or driving or leaving the house. And many times, especially once agoraphobia has developed, this will lead to leading a very limited life because they're not really leaving the house. And I know that many of you probably have a pretty good understanding of how limited your life is and how small your world becomes when you can't leave your home. So here are some typical situations that are avoided by a person with agoraphobia. That includes shopping malls, cars, buses, trains, subways, wide streets, tunnels, restaurants, theaters, escalators, elevators, planes, crowds, stores, supermarkets, waiting in line, being far from home, and staying at home alone. So there are a lot of different situations that could potentially provoke panic that somebody may subsequently try to avoid in the future. So here is a phobia. This man has a fear of dogs. I don't understand why you'd want to have a fear of this cute little corgi, but phobias by their nature are not necessarily rational responses. So phobias will involve fears that the individual recognizes as being irrational. And phobias, in particular, can affect daily existence and reduce the quality of life that one has. So let's break down the difference between a phobia and a simple fear. So, for example, I don't really like big, loud thunderstorms. I know, I'm from Florida. I should be used to them, but I'm not. And especially if the wind is blowing, then I become a little worried about trees. So what I often do is I will put headphones in, or I will put in earplugs, or worst case scenario, I go down to the basement where I at least feel like I'll be safer. So that would be classified as a simple fear. You're not necessarily, I'm not necessarily trying to run away from the thing. I'm just trying to find strategies to mitigate the distress that storms occasionally cause. Now, a phobia would be if I hear that a storm's coming, I'm going to drive to the next state where a storm may not happen. Or if there's even the possibility of a storm happening that day, I won't go into work because I'm too scared. So a phobia is different from a simple fear in terms of the fact that the irrational behavior is much larger, and the extent to which we are willing to avoid it is also much, much greater. So here are some pretty common and also some less common phobias. We have acrophobia, or the fear of heights. That's pretty common. Ichnophobia, fear of sharp-pointed objects or knives. Ailurophobia, which is cats. Algophobia, which is pain. Astrophobia, which is kind of what I might have, storms, thunder, and lightning. Claustrophobia, tight enclosures. Hematophobia, blood. Monophobia, being alone. Nyctophobia, darkness or night. Ochlophobia, crowds. Pyrophobia, fire. Thanatophobia, which is fear of death. And xenophobia, which is fear of strangers or people that are different from us. So, social anxiety disorder. So social anxiety disorder is marked by an extreme fear of being evaluated or criticized by other people. So oftentimes, people who suffer from this will probably not have a lot of relationships. Additionally, they may not necessarily be the kind of person who wants to speak up in class. They definitely are not going to be in situations where they engage in public speaking. They probably don't like big crowded events or parties. So these people will tend to avoid most interpersonal situations. If they can't avoid them, they may suffer extreme amounts of anxiety, which could potentially lead to panic attacks. So here are some of the different emotional and behavioral symptoms of social anxiety disorder. And again, some of these behaviors are more extreme versions of things that we might struggle with. Many of us care about what other people think of us. Many of us worry about situations in which we might be judged. The difference is that most of us, as much as we don't like it, we'll still try to navigate interpersonal situations and will be out in the world. It becomes disordered when it is severely hampering your quality of life to the point where you have no interpersonal relationships. So again, the difference between something that is normal and something that we would consider disordered falls on a spectrum of behavior. So we have fear of situations in which you may be judged, worrying about embarrassing yourself, concern that you'll offend someone. These are pretty normal, but again, the extent to which you're going to avoid these things is going to be much, much greater if it's disordered. Intense fear of talking with strangers, worry that others will notice that you look anxious, fear of sweating, trembling, or having a shaky voice would be embarrassing, fearing events where you might be the center of attention, being anxious, anticipating a feared activity. If you're in a social situation, basically picking apart all of the mistakes that you made and flaws and what you said wrong and what you did wrong. And again, some of us will do this, but again, it's the extent to which we do this that basically demarcates the difference between quote unquote normal behavior and disordered behavior. The onset of social anxiety disorder tends to occur pretty early. Half of affected individuals end up developing symptoms by age 11, which does indicate that probably there's some issues that may be going on in childhood, such as bullying or difficulties at home, that might potentially explain why this develops. Cognitive behavioral therapy can be really helpful with this because For people that struggle with anxiety, really what's kind of critical is dealing with the thoughts, especially those that are really negative. So trying to modify the negative thoughts, such as what will happen if you look foolish, will people care, and social skills training can actually be really, really helpful. PTSD, or post-traumatic stress disorder. Now, it was previously believed that PTSD was something that only occurred in veterans, but this is something that can happen to anybody that has had firsthand exposure to a traumatic experience. This can include things like car accidents, natural disasters, crimes, sexual assaults, and so on. The individual will feel not only fear, but also a sense of helplessness and horror. They may experience nightmares and flashbacks about the event. They may engage in emotional numbing, so they don't really feel the lows, but they don't really feel emotional highs either. They may engage in avoidance. They may have sleep disturbances, and a lot of these people will have sudden outbursts of irritability or jumpiness, or just kind of that sense that they are on edge. Now, there are some genetic predispositions to PTSD. There is a very strong genetic contribution. We do tend to find that in identical twins, if one twin has post-traumatic stress disorder, odds are pretty good that their identical twin may potentially develop that as well. There's a very, very strong concordance there. Additionally, we do know that anxiety disorders and mood disorders do tend to run in families, so there is this strong genetic component. There are as many as 74% of PTSD sufferers that have a family history of some other psychological disorder, including PTSD, anxiety disorders, depression, or antisocial behavior. And we're not talking antisocial as in not wanting to be around people. We are talking about antisocial as in antisocial personality disorder. There does seem to be a little bit of a gender component. Women are a lot more likely to develop PTSD relative to men. That could partially be due to the fact that men are often socialized to not seek help when they are struggling with things. Interestingly enough, for people that are struggling with PTSD, so you would figure, and we kind of talked about this when we talked about mood disorders, that HPA axis and that release of stress hormones like cortisol, you would kind of expect that for somebody with PTSD, that their cortisol levels would be really, really high, but it turns out that is not actually the case. Cortisol levels are actually shockingly low. One of the things that we find is that the normal feedback mechanism that turns off cortisol and adrenocorticotropin releasing hormone, or ACTH, that secretion is actually hypersensitive, and because of that, cortisol gets turned off very, very early rather than at normal levels. And so what we find is that for a lot of people, low cortisol levels end up enhancing the sympathetic nervous system. And so what we find is that despite the fact that people with PTSD have low levels of cortisol, they actually have very, very high levels of circulating norepinephrine. So their sympathetic nervous system is constantly going, but because their feedback loop is hypersensitive and shuts off early, this norepinephrine never really seems to shut off. So what you're kind of looking at here are average blood cortisol levels in children of Holocaust survivors compared to normal controls. So normal controls tended to release blood cortisol at about 65 micrograms per day. And then compare that to children of Holocaust survivors. For those that did not have PTSD themselves or parents with PTSD, the blood cortisol levels matched the controls. For children that had no PTSD but had a parent that did, that was actually lower to 45 micrograms. And then for those who had PTSD along with a parent that had PTSD, that cortisol level was even lower, down to about 32 micrograms per day. So finally, we're going to talk about obsessive compulsive disorder. So obsessive compulsive disorder is marked by two different things. First of all, we have obsessions. These are recurring, persistent, intrusive thoughts of things related to contamination. So things becoming dirty, things becoming moldy, things becoming germy, violence, sex, or religion that basically cause different kinds of distress. So you have these distressing, persistent, intrusive thoughts like somebody that I love is going to get hurt. Somebody I love is going to get hurt. And that causes us distress. So somebody that's struggling with OCD is then going to engage in a compulsion. So a compulsion is a repetitive ritual that is basically done to rid the mind of anxiety, relieve the tremendous anxiety that's basically generated by those obsessive thoughts. So for somebody who might be worried about harm coming to somebody they love, maybe every time that they have that thought, they have to count something or do something 8 times to basically relieve that anxiety. So they're going to keep engaging in these compulsive behaviors to rid their mind of anxiety. So let's briefly talk about some of the neurobiology of OCD. So one of the things that we find is that the caudate nucleus in the basal ganglia, and the basal ganglia is often critical for the formation of habit, is believed to play a major role in obsessive compulsive disorder. And neuroimaging studies have actually found coordinated activity between the caudate nucleus with many different regions of the cortex. So we're going to go ahead and stop here. We will talk about how the brain responds in anxiety disorders next time.